Ladies and gentlemen, distinguished delegates, colleagues from the ASEAN member states and partners, good afternoon. It is my pleasure to welcome you to this lunch symposium on collaborating for resilience, good practice, and lesson learned on education initiative in disaster health management. Today's session forms as an important part of our ASEAN cooperation, especially under the plan of action and metrics detailed activities. Our focus aligns strongly with the disaster health management initiative to education components, emphasizing how education and training can strengthen resilience and advance disaster health management across the regions. We are honored to have with us an excellent panel of experts representing diverse experience from ASEAN and Japan. Over the next 80 minutes, we will explore strategy, good practice, challenge, and innovation in disaster management education. With your lunch, please feel free to enjoy your lunch and sharing experience together. Before we begin our lunch symposium, I would like to introduce overall the keynote. The first keynote is Professor Shinichi Egawa, a renowned expert from Japan with a long-standing contribution in disaster medicine and international collaboration. We will highlight for strategy to enhance a general education initiative with a focus on training costs in disaster management. And the next speaker is Ms. Mariami Urena Cosims, Emergency Care and Disaster Nursing, and expertise on radiation disaster management. And the next one is Assistant Professor Dr. Prashanat Nanthai Vice Dean, Faculty of Nursing, and Deputy Director of Risk and Disaster Management Program, Chulalongkorn University, and also presenting on higher education, integration, and academic capacity building. And the next one is Dr. Yuthanawan Wonghajack, Vice Head of the NCD and Disaster Health Management Division, Ministry of Health, Lao PDR. We are addressing professional and vocational training for the health workforce. And then we have Ms. Maria Carissa Ocampo, Health Program Officer, Health Emergency Management Bureau, Department of the Health Philippines. We will be presenting on innovative digital platform and e-learning for disaster health management. And now, please welcome the first speaker. Please join me to welcome Professor Shuichi Egawa, please.
Thank you very much. Enjoy your lunch. And I am Shinichi Egawa from Tohoku University, Sendai, Japan. And today's topic is about the education for disaster health management in Japan. And I have just a few seconds to present all of my slides. And one thing I want to stress is the importance of terminology. We have heard many numbers of lessons learned yesterday and today. But what is lessons learned? There is no such thing. And we heard also the natural disasters. And there is no natural disasters. Yeah. And we should understand what the disaster means and what the hazard means and what the science means. The lessons learned cannot be the science. The science is the integration of the knowledge, so that we should avoid using the terminology lessons learned and natural disaster to tell our students or tell our colleagues what is the most important to know. That is not the lessons learned. Lessons learned will obscure or blur your idea and the scientific knowledge. This is not my wording. This is a preface of a textbook of disaster medicine published in the United States. So we should think about how we're going to tell our students the findings or scientific knowledge to promote our disaster medicine. That is all what I want to say today. And disaster is a consequence of the hazard. And the hazard attacks the community with various vulnerability and capacity. And the consequence is a disaster. So earthquakes, tsunamis, typhoons, viruses, and radioactive materials, they are hazard and hazardous materials. When they expose to the human or community, depending on the vulnerability and coping capacity, the outcome is different. So we understand this knowledge, not the lessons learned. And when the COVID-19 virus attacks the community was chemical substances, and WHO is classifying the type of hazard like this. And the virus is natural substances. And not, because it's natural, we don't call it natural disaster. We don't call pandemic as a natural disaster. It's different. It's a disaster. And it is not realistic to consider the individual planning for all type of hazards. So we have all hazard approach. And knowing the factors that consists of the risk of the disaster, risk can be calculated the hazard and exposure multiplied by the vulnerability and divided by the capacities. And when we want to reduce the risk, making the upper side smaller and the lower side larger to make the risk much smaller. So this is a scientific knowledge. And understanding that, we can transduce our knowledge to the next generation and the generations 100 years later. And WHO is published the guidance for the research methods for the health emergency and disaster risk management. And I translated this into Japanese, 1,000 pages. We can download it for free. And I wrote the historical development of health area and policy and research. So the policy into practice, practice into research into the practice, and practice into the research. That is the way to go. Yeah. And understanding the cycle of the earthquakes in Japan. And if you see the 400 years of tsunami in the Pacific Rim, we have many tsunamis in the Pacific Rim countries. And the Japanese policy implemented the Disaster Basic Act to reduce the number of victims. But the disaster size cannot be measured only by the number of deaths. We have to understand the health consequences of the disasters so that after onset, we have the disruption of the local healthcare, and that you are the only person who would help yourself the first. Then the EMTs may come in. But the final goal is to reconstruct and recover the local healthcare provider. And the medical needs is not the injuries. If the injuries were reduced, the non-communicable diseases, chronic diseases will be a main health issues in several weeks. But after months or years, the mental health problem of the affected people will become the major issue. And there could be an indirect disaster-related death because of the exacerbation of the non-communicable disease and mental health issues. We have the very nice DMAT system in Japan, and we have the textbooks that was immediately revised after the 2011 Great East Japan earthquake. So this is a practice into the research and education. And we have the disaster-based hospitals, which is usually works as a tertiary hospital of the local healthcare. And this disaster-based hospital is a very interesting feature of Japanese disaster medical system. Understanding that disaster medical system, we can more efficiently cooperate with the disaster situation. And this disaster-based hospital in Japan should have a business continuity plan. And this is a picture of the Tohoku University Hospital, which was located in the downtown Sendai, not inundated by tsunami, but affected by the shake. However, we reconstructed, and the This is a demolition-free anti-seismic retrofitting. We didn't destruct the building, but cut the building between the first floor and the second floor and inserted the anti-seismic mechanism without demolishing this building. So it's a very cost-effective manner to make your hospital resilient against earthquake. And this is a damper of the seismic absorbing. And the fuel tank for 1 week was strengthened as a business continuity plan. And we have the actual documentation of the business continuity plan of our hospital. And this is a situation of cabinet, national government designed training for the simulation of the coordination center. So this is a model of the EMTCC in Arch project. But we have to understand the health consequence of the long term after disaster. So after surviving the direct earthquake-induced death, we have this number of indirect death. So in the Great East Japan earthquake in 2011, 3,789 people died within 10 years duration after surviving the shake. And when we see the Kumamoto earthquake in 2016, Noto Peninsula earthquake last year, the number of indirect deaths exceeded the number of direct deaths. So the health consequences of the affected people is going to shift from the direct emergency care to the indirect chronic care, mental health care support that is necessary for the future disaster response. And this is our educational system, but I'm not going to into the detail, but our institute, the IRIDIS, is a very comprehensive research institute of Tohoku University. I am a medical doctor. I'm working with engineers, seismic scientists, tsunami engineers, and also the social scientists as a comprehensive research institute of the disaster. So disasters could be multifaceted and multi-aspects science. And the WHO's Health Emergency and Disaster Risk Management Framework is offering the paradigm shift from event-based to risk-based and from reactive to proactive, all hazard approach, from hazard focus, from hazard focus to vulnerability and capacity focus. Japan is reducing the vulnerability and increasing the capacity. Though the risk of hazard in Japan is very high, Japan has achieved long life expectancy and low risk in disasters. And from single agency to whole of society, shared responsibility of health system with other sectors, and from response focus to risk management focus, and from planning for communities to planning with communities. So we should be inside of the communities. And this is a good practices and gaps in Japan. And I am not using the lessons learned as a terminology. So we have to understand what is good practice and what is a good, important knowledge to understand and what should be avoided. Thank you very much.
Thank you very much, Professor Egawa, for your presentations. The floor, do you have any questions for Dr. Egawa? Okay, please. Medalina, please proceed to the microphone. Yes, thank you.
Hello, good afternoon. I'm Adelina from Hiroshima University. Thank you, Sensei, for your presentation. I just realized that the terminology is very important from during the learning process. I don't have any question, but I just want to stand that I totally agree with your perspective, Sensei, because in Indonesia as well, people talk about disaster. They call disaster even for like no people affected. Just earthquake happen, and no, sorry, just a flood, not flood. Example like small accident, and they call it disaster. And when we move to the, maybe when we build a hospital disaster plan or training, it's make confused for our participants. So I totally agree that the terminology is so important in during the learning process. Thank you very much, Sensei.
Thank you.
Dr. Jirot.
Thank you very much for your presentation. I do agree with you that I think disaster risk management. I think it's not a professional uh, uh, um, authorities. It's not the professional, but we should idea like it's a social response, not only the professional response. That knowledge of prevention is very important. That we, for the academia, for the university or higher education unit, maybe we train like a bachelor degree or something like that, but the knowledge is maybe not only at the bachelor degree, maybe in basic knowledge, it should be disseminated to the society also. For example, the tsunami in Thailand, I have heard that the children can notify the the low tide before tsunami, and they uh, they uh, tell others, but no one not respond because no idea or no experience. But that children's run and save, then the knowledge is not only for professionals. I think uh, we should make that like a module of knowledge to many level of people in the society also. For example, in Thailand during COVID, we have a community health volunteer that is a basic the villagers, but have a knowledge of public health that can save themselves and also the villagers. That is a strong point of Thailand. I think knowledge should be disseminated to many level.
Yeah.
Not only like a standard bachelor degrees or some degree, because sometimes the degree is not a matter.
Correct.
Yeah.
Right. Thank you very much. This reminds me the importance of the risk communication or scientific communication. And usually the scientists are understanding that telling the truth will convince the people, but that is not the real. And the communication should be the mutual understanding. So scientists should know about the people's understanding level or people's perception about the risks. And people should understand what the scientists want to convey to the general population. So, so this kind of sitting together in a calm environment and talking with each other in trustful manner, so that will convey a good communication and increase the knowledge level of both sides. Thank you very much.
She still have questions.
No problem.
Okay.
I have two questions. I'm Patranit from Jurapan Royal Academy. The first question is just for a confirmation for Thai people as well, because we just faced earthquake during at the end of March this year. So because disaster is involve preparedness and capacity building. So would you say that earthquake is not disaster in Japan anymore because you have preparation? The first question. And the second one is, could you please give us an example of planning with community? How do you do with the community? Because we need to raise public health awareness a lot in order to get them to be involved with us in planning. Thank
All
you.
right, thank you very much. For the first question, we have like 100,000 of earthquakes every year. So not each earthquake is a disaster. But when the disaster strikes strongly the community may have a damage. So that the building that collapsed in Bangkok in March by the Myanmar earthquake was under construction. But the completeness of the seismic strength was not achieved at the time of the building. So it could be many factors that defines the how hazard becomes a disaster. So it depends on the coping capacity of Thailand government. We heard a very nice presentation from the Deputy Director of the Ministry of Health this morning. And also the second question, how to involve that planning with the community is a word of WHO. And I agree with that WHO, and the framework was developed after the Sendai framework for disaster risk reduction, involving the stakeholders, new stakeholders. The main stakeholder for the disaster risk reduction is the national government, no doubt. And national government has a responsibility to take the responsibility. However, we have to hear the opinions and the requirements of the various people with vulnerability, people with disability, pregnant women, youth and children, older people, or international residents are living in many countries. Japan also has many international residents who do not exactly understand what the government is saying at the time of disaster. So they have some vulnerability by themselves. So we have to hear these opinions and consider how we can prepare the planning. That is probably the answer to answer your question. Thank you.
Thank you very much, Professor Ekawa. Because the limitations of the time that we will move to the next presenter.
Okay, we will proceed to our panel presentation from ASEAN member states, each sharing practical experiences and education model in disaster health management. Our first speaker is Ms. Maria Carissa Ocampo from the Philippines, who will highlight the development of education system and DHM training platform that enhance national and regional readiness. Please welcome Ms. Ocampo.
Good afternoon, everyone. I hope you're still enjoying your lunch or what's left of it. Again, my name is Maria Carissa Ocampo from the Health Emergency Management Bureau of the Department of Health Philippines. So for this afternoon, I will be sharing with you innovative digital platforms in e-learning for disaster health management. So to give you a brief background, our emergency medical teams, locally known as the Health Emergency Response Teams or the HERTs, have minimum training requirements that they need to complete. So for the public health team, they are BLS, SFA, Health Emergency Response Operations, and the subnational public health emergency management in the Philippines. And then for the hospital team, We have BLS, SFA, the Health Emergency Response Operations, the Mass Casualty Management Training, and the hospitals safe from disasters. So with numerous training requirements that our health emergency response teams have to go through, the Department of Health has developed the DOH Academy, which is actually an open source e-learning platform which provides online practical and beneficial healthcare training to all health workers. So this is how the DOH Academy e-learning platform looks like, and the site is accessible through the link www.learn.doh.gov.ph. So DOH initiated e-learning courses can be developed in-house by the technical office. So in the case of the health emergency management, it will be the Health Emergency Management Bureau of the DOH, or through hiring a service provider or a consultant, or even through sponsorship of our development partners such as the WHO. So all e-learning courses are offered for free and applied for continuing professional units, or what we call the CPD units. So the CPD Act of 2016 requires professionals in the Philippines to complete a number of accredited learning activities, such as trainings and seminars, to remain competent and eligible to practice their profession. So shown on the slide are the CPD units granted per profession. So we have CPD units for dentistry, medicine, midwifery, nutrition and dietetics, nursing, and so on and so forth. These were CPD units granted per profession in 2023 and 2024 from the trainings which were uploaded through the DOH Academy. So one of those trainings that was converted into an online course is the Basic Life Support training, at least for the didactic portion of the course. So this online didactic course is actually complemented with a face-to-face skills evaluation and return demonstration. So the Basic Life Support online didactic course covers 3 competency units as listed on the slide. The standard first aid videos, which include bandaging, splinting, and lifting or transferring, were also developed to facilitate the conduct of the first aid training up to the community level, since we all know that the Philippines has 3 major islands and we have numerous geographically isolated and disadvantaged areas in the Philippines. So these videos of the SFA were developed to ensure that every learner also receives the same instruction. So another one that was developed by the DOH is the introductory course on disaster risk reduction and management in health, which introduces participants the concepts of health on DRRM, and it also focuses on the health impacts of the emergencies and disasters and how these are addressed within the following thematic areas. So that's prevention, mitigation, preparedness, response, recovery, and rehabilitation. So what are the advantages of developing e-learning? One is that we expand access and reduce the costs, especially to the government. So courses can be delivered anywhere with internet access, and often there are courses that are also offered offline. Micro-learning and modular formats make training compatible with work schedules of our health workers. Digital modules replace the need for physical classrooms or printed materials, and learners can participate without travel, which greatly expands its reach in rural or low-resource settings. Another advantage is overcoming geographic and social barriers. So digital delivery removes geographic constraints, and courses can be translated, captioned, or adopted into local languages for accessibility. And then lastly, leveraging technology to improve learning outcomes of our participants, and that's the healthcare workers. So standardized content ensures every learner receives the same instruction. Updates to course materials cascade instantly to all learners, and interactive quizzes, gamifications, and multimedia content reinforce engagement. So to end my presentation, allow me to leave you with a quote. Digitization doesn't replace learning, it expands its borders. Thank you very much. Should you have any questions, Dr. Danak would be happy to answer your inquiries. Thank you.
Thank you very much, Miss Maria. I open the floor for the any questions for the e-learning. Okay, Dr. Natsukawa, please.
Thank you for smart presentation. I have a question about who can access to the e-learning site. So every people in Philippines or doctors or nurses, also some definitive defined person
Population.
can access to the e-learning.
The target population for the development of the DOH Academy is actually the healthcare workers. But the public could also access the platform, considering that they would register or sign up so that they'd be able to get access to the course. It's just that although all of the courses are actually for free, but there are certain courses that would require an access code. The purpose of the access code is that so that the technical office who's the author or who developed the course would be able to monitor the participants who are trying to complete these courses.
So you mean the student in the college or university can access to this site?
Yes, as long as they do sign up to the e-learning platform.
Oh, very good, I think. Thank you.
Thank you.
I saw Dr. Patharanit have some questions.
May I ask, would you include this e-learning into the professional development certificate for people, like if they wanna they wanna continue their professional certificate? Would you include this e-learning into account as well? And also, can those college students collect the credit as a credit bank and then make it as a learning for them to develop and go further on with their education? Thank you.
Thank you, Dr. Nice. Well, actually, I think the limitation of the DOH Academy is that it only provides training courses. So these training courses are actually still not part of the academic or the curriculum of our students. So going back to the previous question, if a student would like to access one of those trainings at the DOH Academy, he or she may register. It's just that the training that he or she is going to complete is actually not part of their curriculum yet. So it's more of capacity building activities or learning and development interventions, specially created or developed for our healthcare workers.
All right. Thank you very much, Mr. Campbell. Our next presentation is from Assistant Professor Dr. Pachanat Nanthai Thavikul from Thailand, who will present Thailand's good practices in curriculum development and academic collaboration in DHM education. Dr. Pachanat, the floor is yours.
Okay, thank you to moderator for the suggestions me, and hello everyone. It's not too late to say welcome to Thailand and hope you happy Wednesday in the Thailand. It is and my honor that to share information about the curriculum in Thailand for everybody and to thank organizer to invite me. To create continuous and consistency covering all area in this section, I would like to mention the role of educational and the curriculum and learning teaching in Thailand, which are related to disaster health management. Okay. How disaster health management is integrated into the curriculum in Thailand. In this level of the academic curriculum in Thailand, I would like to divide academic level related to teaching in Thailand into two main groups. The first group in the academic curriculum. Academic curriculum is the undergraduate program. The next is the graduate or master degree. And the third is the PhD course. Another main is in the short course, intensive course, training project, and certification, including medical, clinical trial, public health policy, environment health program, and policy and health public, and the other curriculum. So in the undergraduate program in this semester in the Thailand, we have many curriculum in Thailand. For example, in the center of area in the Julapon Royal Academy, Chulalongkorn University, Ramathipodi Hospital, Mahidol University, Thammasat University, Navamin University, Dusit University, and Hua Chiao, and in the Chulalongkorn. And another point in the previous area, we have in the Nalesuan University and Mae Fah Luang University in the north of the Thailand. We have the Prince of Songkhla University and Valailak University in the south of the Thailand, and another Southeast Thailand in the Khon Kaen University and Mahasarakham University. Another is the graduate or master course in the disaster and PhD. For example, in the Chulalongkorn University, we have the program of Risk and Disaster Management or RDM program. Another in the Thammasat University, Nalesuan University, and AIT. And they have many curriculum in other university. Okay, this I would like to show in the short course. For example, we have many courses in many countries. And many in the university in Thailand. For example, in Thammasat, in the program of the DRMIS in Chulalongkorn University, or ADPC, or TNDR, or in the Navy Medical Corps, JICA, ASEAN, MOPH, and NIAM. This is for this only this sample. This slide I would like to show the short course in the learning and teaching in the course in Thailand. For example, water rescue course. This is the show in the picture. Another picture is the seminar on earthquake survivor by TNDR in the medicine team. This is shown in the teaching of practice in online and offline. This is the community-based disaster management that practiced in the curriculum in Thailand. Another is the innovation that we are develop intervention is telehealth self-management innovation when have the COVID-19 in home isolate. This is the project that we are develop. Another reference in the fire survival and safety in the part of the activity in the bachelor degree, as same in the activity in the car disaster and emergency care in the Chulalongkorn University. This is the Kobago. That Kobago is start in the 2022 and to the present. So now we have the USA medical unit. The medical law in the urban search and rescue team. This is the news. Okay. As we know, when we analyze the various curriculum, current tasks in the Thailand. I was found that there are both strengths of this curricula and point of should be improved as follows. Strength and trend in the curriculum in Thailand. The first is in the interdisciplinary approach. This curriculum based environmental health, public health, emergency medicine, risk management, policy, and communicate. This is necessary for disaster health touch many fields. The other is the practical and policy relevant content. Course of offer cover risk assessment, early warning, response system, health system resilience, community-based disaster risk reduction, and hospital preparedness. The other is partnership. University partner is the external agency, for example, for the ADPC, for the TNDR, for the JICA, for the ASEAN, to run crisis model. It which gives student exposure to real world situation of the disaster risk management. That is the professional training. Beyond academic degree, there are targets in this, the professional. But however, we have the challenge, the gap of the curriculum in Thailand. The first, not university, embedded in all medical program, while some public health and environmental health program include disaster module. It's not guaranteed is very in every curriculum. The other is limit of specialists. Very few higher specialists in disaster health management, especially in master degree. The focus purely on health disaster as opposed to general disaster management. The other is the resource constraint. For practitioner disaster training, simulation will work. Not all universities may have capacity. The last in the alignment with National Disaster Health Policy, translating academic trainer into the public health workforce and emergency health response request strong coordination. It may be in constancy. Conclusion: disaster health management is the responsible well integrated into Thai higher education, especially within public health, environmental health, and emergency medical program. There are both dedicated disaster health degree, bachelor and master degree, and modular disaster health content, which in broader public health, medical curriculum. This help prepare a workforce that can respond to disaster for health system, environmental clinic, and policy respectively. So this is the mechanism and partnership that support sustainable and accreditation of the HM program. The first is the National Accreditation and Quality Assurance Mechanism. The second is the government, university, and partnership. The third is the international and regional partnership. The fourth is the university, hospital, and community network. The fifth is the workforce, driver demand, and professional recognition. Faculty development and academic capacity building. Research and funding partnership. This is necessary to maintain in this program. ASEAN level collaboration can significantly strengthen the integrated of disaster health management into higher education curriculum in several ways. For example, ASEAN can join course, share curriculum, share activity and standard, and regional center of excellence, and student and faculty exchange. The next for the sustain and expand education to the regionally. Okay. I'm so sorry. Sorry. Okay, thank you. To sustain and explain and education to the dictionary, the synthesis between academic and legal context require the academic sector to translation its knowledge from community outreach. Integrated community participants to paramount to ensure long-term sustainable. For example, the concept that related to sustain concept of knowledge transfer from education institute to local community. The next is concept of needs of the regional because the need is necessary for to prepare for everything in this. Concept of community-based disaster risk management (CBDRM) is necessary for the sustain in this. Okay. To connect academic knowledge with practical knowledge or in every legal, a network has been created. This is the example that the Thai Network for Disaster Resilience or TNDR. TNDR network is now we have the mission in the ICCC, innovation, collaboration, capacity, and communication. Now, in the CNDR, we have the 20 university and partner for manipulate everything in that related to disaster management. And health disaster management is the one mission in this the CNDR. And we have the partner in this classroom in this group. This is the partner now that CNDR make in everything, for example, research, anything in this share together. Okay, thank you so much.
Thank you very much, Dr. Pachanat from Chulalongkorn University for sharing the how to organize the curriculum in the universities and also other related training to the DHM in Thailand. Thank you very much. So we don't have time for the questions that if we have time at the end of all of the presenter have presented, that we will come back to the Q&A sessions. Okay, next.
Okay, next we invite Dr. Mariami from Indonesia, who has been a key contributor to education initiatives. She will discuss the innovative learning models and lesson learned from Indonesia DHM programs. The floor is yours.
Okay, thank you very much. So I've heard a proverb stated that preparedness is not built in a single moment, but in every moment people choose to care. And today, that message feels especially real for me. So good afternoon, distinguished college. Before I begin, allow me to share something personal to this session. So our dear colleague, Dr. Bella, who was originally scheduled to present today, unfortunately had to return immediately to Indonesia last night. And since her mother was suddenly admitted to ICU, and as we all understand deeply in the world of disaster health management, when a family emergency happens, responding with compassion becomes our first duty. So on behalf of AIDHM, we ask for your understanding and we extend our thoughts and prayer to Dr. Bella and her family. So in the spirit of solidarity, which is the heart of our work, I will be presenting in her place today. So let's begin our presentation. So every disaster teach us something. Sometimes it's about system, sometimes about coordination, and sometimes, as in Dr. Bella's situation, for example, about the very human of emergencies. And that is exactly why disaster health management must be part of higher education. Because disaster do not wait for us to be ready. Our students, our future health professionals must learn not only science, but the compassion, coordination, and leadership needed when lives depend on their decision. So this presentation follows a simple idea that shapes all of our work in Asian. Education builds understanding, understanding builds coordination, and coordination builds resilience. This is the path we walk together in this Asian Academic Conference, a path where knowledge becomes action and evidence becomes improved practice. Oh, sorry. So my presentation isn't okay. You can show the slide. So sorry for misunderstanding. Sorry.
While we are waiting for the presentation, any questions from the floor? First to the previous presenter, Dr. Bachanat. While we waiting for the presentation. Okay, Dr. Nasikawa, please.
I have question for the former presenter. So in Thailand, how many hours for the disaster health management in university? In Japan, just 1 or 2 hours. So just introduce DMAT or triage. But I think it is not enough for the disaster health management. So as for Thailand, how many hours state students study the disaster health management?
Do you mean the disaster health management in all the program in
Yes,
the university,
in
right?
university, so medical faculty.
Yeah, yeah. Dr. Pachanat or Dr. Nice can answer from the universities.
In the curriculum for health disaster management in Thailand, we start in the bachelor degree, and I think that in the master degree has in the, I'm not sure in the Sovereign has the master degree in here, but I'm not sure in the Julapon that it is in it man. น่าจะมีนะพี่ไม่แน่ใจ
May I add more information on these questions? If we focus on the bachelor degree, I would say that for medical students, there are 1 or 2 hours, as you said, but we also ask them whether they want to know it or not. As a student, they've obviously said that, no, we don't think that we need to know that. But in reality, when they graduate and they are intern in other hospital, usually nurses always promoted them to be either incident commander or the head of the planning section. So it's in fact really important for medical students. So right now for Julapon Royal Academy, because we had disaster center with Julapon within the university, we are trying to force the students to know, encourage, I would say, may I change the word to encourage. We try to encourage all bachelor degree healthcare professions to know this kind of thing. And for my the curriculum that I look after on, it's a paramedics bachelor degree. I included it into the whole program as a longitudinal courses. So they will have, within this 120 credits, they will have around 20 credits to learn about this. Are you okay? Sorry.
Thank you very much, Dr. Pathalanit, for your sharing.
Yeah.
Back to Dr. Mariami.
Okay, thank you very much. Sorry for emergency, but we find that sometimes emergency also blessing in disguise because we can discuss about this again. And that one is actually related to this presentation, this integration into higher education, universities and academic institution, embedding DHM modules in medical and public health curricula or university-led simulation exercise. I cannot Okay, so first, allow me to show our AIDHM team into this picture. And this is the outline of my presentation. So first, integrating DHM into higher education, introduction of AA and DHM. So because disasters increasingly affect our health system, like in Indonesia and across Asia, we face frequently emergencies from earthquakes, floods, and volcanic eruption to disease outbreaks. This event don't only cause physical damage, but also disrupt essential health services. And when hospital and health workers are not ready, the health impact becomes much worse. So second, our traditional medical and public health curriculum often focus on clinical care and disease prevention, but they don't always prepare the student for crisis situation. So like previous presenter stated before, the future doctor, nurses, and public health professionals need to understand how to lead during emergency, coordinate with non-health sectors, manage logistics, and make decisions under the pressure. That's where disaster health management education become essential. And thirdly, embedding DHM modules help build readiness, coordination, and leadership among the next generation of health professionals. It's not just only knowing how to treat patient, it's about understanding how to manage system under the stress, how to communicate risk, and how to collaborate effectiveness around across institutional and countries. So, and finally, the universities play a key role. That they are not just teaching institution, they are knowledge hubs that generate evidence research and innovation. By integrating DHM into curricula, universities contribute directly to national resilience, to Asian collective capacity to respond to the crisis. So integrating disaster health management in higher education ensures that when the next disaster happen, our health professionals are not only skilled, they are also system aware, coordinated, and ready to respond. So this actually represent so this one is the integration of disaster health management in higher education. Oh, okay. So in this slide, actually the main activities of AIDHM to put practice into research, put evidence into practice. So probably Professor Yodi previously has already showed this slide, but we can see how AIDHM connect different elements of practice, research, and education in disaster health management, creating a full learning and evidence cycle. So here, here at the center, we have the Asian Journal of Disaster Health Management and Asian Academic Conference, just like what we are doing currently. These two platforms allow us to share knowledge, experiences, and research finding among Asian member states and our international partners. And this process starts from the actual disaster practice. So start from actual disaster practices. Then AIDHM has a function to document and analyze the real experience, turning them into research activities or what we call Asian joint research. Here, once the research is completed, the next step is writing the scientific papers and presenting them into the Asian Academic Conference on Disaster Health Management. This way, practical lessons that we learn from the field are translated into research finding and shared regionally and internationally. Then through the AJDHM, Asian Journal of Disaster Health Management, these studies are published and made accessible to policymakers, universities, and practitioners. This our objective is can be helped to ensure that evidence and best practice are not kept in the academic level only, but are used to inform real decision and education system. So from there, the knowledge field directly into evidence-informed policy recommendation and also support the development of the training and educational curricula across Asian universities and health institutions. So once again, put practice into research and put evidence into practice. It means that we learn what we learn in the field becomes science, and what we learn from science goes back to improve our field response and our communities. So current Asian situation. Across Asia, several universities has begun integrating DHM into their program, just like our previous presenter has already shown that actually quite a lot. And for example, like in Indonesia itself, like in UGM, or previously from Thailand and also Philippines. However, this effort sometimes still fragmented and quite widely in scope and quality. That's why we actually need a shared competency framework and standardized DHM curriculum, which AIDHM can make sure or doing its function to coordinate to ensure harmonized capacity across the region. So here we found there are two main challenges. First, the fragmentation that each country and universities is developing DHM education independently with different structures, topic, depth. And secondly, there are lack of common standards. There are no unified competency framework or agreed learning outcomes across Asian, which actually we don't have to make it similar, but at least we know the basic one which should be learned by, across the Asian, because the differences sometimes make it difficult to compare the program, recognize the qualification, or coordinate training regionally. So that's why moving toward standardization and collaboration, AIDHM and also the Asian Health Cluster is become increasingly important. So the role AIDHM here, this role of AIDHM and how is first AIDHM can act as regional knowledge platform. We can facilitate knowledge exchange among universities, health institutions, and national disaster management agencies that include sharing curriculum materials, good practices, and lessons learned from different Asian member states. Through this exchange, we aim to harmonize DHM learning across the region, especially in the context of Asian academic network. So secondly, AIDHM help develop standardized DHM curricula and training materials. We collaborate with experts and universities to design modules that align with the Asian Health Cluster Plan of Action and WHO Health DRM framework. This module can be adapted by universities according to their national context, ensuring consistency while maintaining flexibility. So third, AIDHM support faculty and faculty development. We organize training of trainers, programs, and regional workshop to build teaching capacity in DHM and help EDRM. Because of course, one of the challenges in Asian is the limited number of qualified faculty. This offer help universities to strengthen their own teaching teams. So the fourth is to AIDHM facilitates simulation-based learning and regional exercise. We encourage university to conduct joint disaster simulation. Yeah, okay. Either in the national level or through a collaborative exercise. The simulation bridge theory and practice, helping student, faculty, and practitioner test their coordination and decision-making skills in realistic scenario. Fifth, AIDHM promotes research and innovation in disaster health. So we support collaborative study across Asian countries on topics such as hospital preparedness, emergency medical response, risk communication, and community resilience. Our goal is to generate evidence that strengthen regional and national politics. So, yeah. This is the one that probably we can do together to build the Asian DHM competency framework and then curriculum toolkit, university simulation, and strengthen academic partnership and collaboration. Yeah. Okay, thank you very much. That's all from me.
Thank you very much. Now we proceed to our last presentation from Dr. Yuthanawan Wonghachak from the Lao PDR, who will share experience on strengthening the DHM education within the national context and fostering ASEAN collaboration. Please welcome Dr. Yuthanawan.
Okay, thank you very much, Mr. Chairs, and good afternoon. Actually, a little bit confused. I don't have any presentation, but I will share. We're talking about just a few minutes for our DHM and education in Laos. For disaster health management course in Laos, we don't have any DHM course in Laos, but we also we only have that like a medical emergency in for medical student in bachelor degree, and also we have medical emergency for postgraduates, and also short course for health profession or nurses, and also public rescue team, like basic life support course that's organized by Mitapap Hospital in the Vientiane capital. This is like in the course organized by Medical Emergency Association of Laos. That's the approved public rescue team should be attend the basic life support course from our medical emergency association. But anyway, there are many public rescue team that's not involved, or they don't want to have the course from Mitapap. Right now, from our records, just only 5 public rescue team that got training from Mitapap hospital team to get, and the hospital certify them as public rescue team that can service in Lao PDR, I mean in Vientiane capital. However, sorry, as the national target of disaster management for ASEAN. Maybe, yeah, as I remember, this is the target number 5. We also will try to have some disaster health course in our education. We also set some indicator for this, and we'll discuss with Ministry of Education and also the University of Health Sciences to discuss and to see the possibility to include disaster health management course in our medical curriculum, both medical students and nursing or for health profession. And this is our planning. And moreover, for as I present today in the morning, Lao not have so much severe disaster, but right now we consider for CBRN, chemical, biological, radio and nuclear disaster, because in our country right now there are many investments like Preto investments, and also there are many chemical factory we come to a lot of, and we also think about that if some chemical incidents occur, how to manage. Right now we don't have any regulation or any causes to respond that. And thank you very much for invite me to this presentation. Thank you.
Thank you very much, Dr. Yuthanawan, for sharing about the Laos experience on conduct the educational on disaster health management in the many level. The time is up now because we need to proceed to another sessions. I will conclude today's sessions. Allow me to wrap up the key message from our discussion on strengthening education initiative in disaster health management under the ALD on DHM. Across the presentation, we heard 4 important themes. First is university and higher education institutions are increasingly integrating DHM into their curricula, but there is a clear need for greater standardizations across the ASEAN that the AIDHM had mentioned. Second, professionals and vocational training remain essential for building a competent frontline health workforce, and efforts must be focused on sustainability and accreditations to ensure long-term impact. Third, community-based and school-level education plays a crucial role in the building public awareness and preparedness, reinforcing that resilience begins at the local level. Fourth, the Philippines presented digital learning innovations from online courses to simulation tools, other tremendous potential to bridge resource gap among member states. Looking ahead, we encourage ASEAN consider developing a regional reference framework for the DHM education, strengthening coordination between health and education sectors, and expanding the use of digital platform. Thank you very much for all of participants and the speaker today. I will close this session. Thank you very much.
Thank you, our moderator and Dr. Kiengsak Pintatham, Ministry of Public Health, Thailand, and Dr. Kawin Tiyawat, Vice Dean of Technology and Health Science, Nawabintara Thirat University. And may I invite Dr. Jiro Sintawanon to present the souvenir from speaker and take a photo together. Yes, please.